So my name is Dr. Joshua Royce. I'm a thoracic medical oncologist at Georgetown University and assistant professor of medicine. And I'm privileged to be here today to speak on non-metastatic disease and targeted therapies, a very rapidly evolving space. These are my disclosures. I want to begin by discussing kind of a visual glossary of terms. I might be throwing in some medicalese accidentally, and I just want to describe some terms and what they mean in the context of targeted therapies and non metastatic disease. So, when we look at someone who's potentially can get surgery for what we say a resectable non small cell lung cancer, if we give treatment before surgery, medical treatments, that's called neoadjuvant. That means giving chemotherapy, immunotherapy, targeted therapy before surgery. If we give these treatments after surgery, we refer to that as adjuvant, giving medical therapies after surgery. And then more recently, as we have more evolving trials, we've kind of referred to lumping treatment both before and after surgery as kind of a perioperative technique. So that's one thing I wanted to get across. The second has to do with outcomes and disease free survival and overall survival. You might hear us throwing these terms around occasionally. And so let's take, for example, a 10 patient clinical trial. And a year later, you look at follow up of a 10 patient trial in patients who have a curable lung cancer. Of these 10 patients, five are alive and disease free. Three are alive, but unfortunately have experienced recurrence of their cancer, and two, unfortunately, have passed. At this 1 year time point, the disease free survival, meaning percentage of patients who are alive and without recurrence of their cancer, would be 50%. However, the 1 year survival rate would actually be 80% because while five patients are alive and disease free, there are actually three who are alive and have experienced cancer recurrence. So, just an explanation for some terms that we utilize in this disease setting. So, where were we in treatment status for patients? Up until very recently, the only thing we offered patients with resectable lung cancer was chemotherapy. And you could see the long term survival outcomes were really abysmal for this stage of disease. For stage 1B to 3B, survival rates of 24 to 73% at 5 years. And really, the benefit of chemotherapy was limited to about 5% at 5 years, whether it was given before surgery, neoadjuvant, or after surgery, adjuvant. You could see on these curves. I know these slides appear a little small, so definitely download these, look at these more closely, but I'll try to discuss them in detail. So the top line of both of these curves is giving chemo, and the bottom line is no chemo. And you can see while there's a benefit, it is not as high as we'd like to see. So, how has this field changed? And really, the big trial here was the phase three Adaura trial. This trial randomized patients with completely resected stage 1B to 3A EGFR mutated lung cancer to osimertinib, our frontline targeted therapy standard for EGFR mutated lung cancer, or placebo. And I'm going to walk you through the study design here. So, on the left are the inclusion criteria. So, this study included patients with, again, resected stage 1B to 3A non small cell lung cancer. And this utilized a slightly older staging system. So, roughly translated, this correlates mostly with stage 2 and 3A patients with today's staging, though it did include some stage 1. These patients had to have an activating EGFR mutation. So, our classic EGFR activating mutations, exon 19 deletion and exon 21 L858R mutation. And patients were randomized, patients were then stratified by disease stage, by the type of EGFR mutation, by race, and then randomized 1 to 1 to receive 3 years of osimertinib or placebo. The primary endpoint, so how the study was designed to look at a clinical endpoint, was to look at disease free survival, as I said earlier, time to cancer recurrence in the higher stage 2 and 3A patients, but key secondary endpoints did include overall survival. So, as this figure shows, the disease free survival was remarkably positive with this trial. You could see out 4 years from the beginning of adjuvant targeted therapy, an incredible disease free survival benefit with 70% of patients who received Tagrisso at the stage 2 and 3A patients alive and disease free at 4 years, compared to 29% who received placebo. And this roughly translated to a 77% disease-free survival benefit for osimertinib over placebo. Again, this is in the primary population that was looked at, the stage 2 and 3A patients. And when looking at all patients, so including the 1B patients, a very similar, very impressive outcomes, again with a 73% disease free survival advantage. Now, because of this data, in 2020, the FDA actually approved osimertinib for therapy after surgery, interestingly enough, for all patients with EGFR mutated lung cancer with these alterations in exon 19 deletion and 21L858R mutation. So, irrespective of disease stage, and what this really speaks toward is that we should really be considering next generation sequencing for all patients with a resected non small cell lung cancer to evaluate for an EGFR mutation.